Okay, welcome everyone. We are going to begin our webinar. Claims data shows IDN's worth, reaching sales and business objectives through understanding IDN value. This webinar is sponsored by Lexisnexis Risk Solutions Healthcare. If you'd like to ask a question during today's webinar, you can type your questions in the Q&A tab, and preferably not the chat. We are monitoring both, but the Q&A tab will help us keep track of your questions. We will be allowing time for questions at the conclusion of the presentation, and please note that this webinar is being recorded. And at the end of the webinar, I will put a link to the evaluation in the chat. I will also email you all the evaluation link to complete. Kindly do so within a week. And also be sure to visit the PMSA website for upcoming webinars and for the recording of this webinar as well as past. Okay, I will now turn it over to Anya from Lexisnexis to begin the webinar.
Great, thank you. So thanks everyone for joining us today. My name is Anya Matungiewicz. I'm a vertical solutions consultant for MarketView. That's Lexisnexis's product suite built on medical claims data. Presenting with me and kicking off our presentation is Rebecca Hauk. She is the manager of healthcare strategy, also specializing in MarketView.
Thank you, Anya. I'm just going to move to our next screen here. And thank you everyone for having us here today. We're excited to be here with you. So today we will run through the state of the healthcare industry and current challenges, really talking pre-COVID first, and then we'll spend a little time on the impact of COVID-19, and then discuss how using claims intelligence helps bring greater insight when evaluating and trying to understand the integrated delivery network, or the IDN. So let's start with discussing the state of the industry. As we all know, healthcare is a constantly evolving and shifting market influenced by policy and regulations, a landscape of big but sensitive data, and in recent years under constant pressure to reduce costs and show greater quality outcomes. Over the next few slides, we'll discuss these and other industry trends that are shaping the landscape, from the products you develop to the providers and payers who ultimately use these to treat their patient populations. So first, as we all know, the market has been shifting from volume to value, with the emergence of alternate payment models, or APMs, indicative of value-based care approaches. Level setting, 10 years ago or so, healthcare insurance was paid on volumes, as we all know. Over the past decade, we've seen a shift from the number of services to the quality of those interactions, with market attention driving an increase in accountability. Volume-based reimbursements are still commonplace, though beginning to trend toward a value-based model. So in the market today, we see four major categories of payment models. Category one are traditional fee-for-service payments. With no link to quality, these payments are not adjusted to account for either infrastructure investments, provider reporting of quality data, or provider performance on cost and quality metrics. Category two are fee-for-service payments linked to quality. So you'll see on your bottom left here, we're looking at the payments that are adjusted based on infrastructure investments to improve care of clinical services, whether providers report quality data or how well providers perform on cost and quality metrics. Category three at the top right are payment models built on the fee-for-structure architecture, providing mechanisms for effective management of a set of procedures, an episode of care, or all health services provided for individuals. These track cost and performance and hold providers financially accountable for performance on appropriate care measures. And this is where we start to see the upside rewards for appropriate care. And then category four in the bottom right are population-based payments, driving providers to deliver person-centered care. These payments hold providers accountable for quality and person-centered care goals, including preventative health, health maintenance, health improvement, and acute or chronic care services. So of these category types, APMs account for 35% of payments or so, but they represent 77% of the covered population, or roughly 226 million Americans. This shift represents the move to consumerism, or a patient-centric approach. And while fee-for-service continues to represent a high percentage of payments, the fee-for-service decline is really underway. We've seen a decline, 2% or so since last year alone, and many industry goals to see APMs grow to 50% or more within the next 5 years. So in addition to the shift from volume to value, we've also experienced a firm shift towards patient responsibility. So patients are charged with greater ownership of the financial burden for their health care. This is hallmarked with a shift from PPO to high deductible plans. Employers are seen to be lowering costs while increasing monthly patient insurance costs. And the results are our patients are paying more out of pocket, right? And this is changing their buying decisions. So if you look to the right, you'll see in a survey from Bloomberg that percentage of Americans who had moved to high deductible plans has really grown considerably since 2010. So as patients are more responsible for their healthcare costs, there's an increased need for price transparency. So last year, we saw the execution of a new presidential order requiring hospitals to publish prices that reflect what people pay for services. This action, which is a step beyond what had been started through the ACA's requirement for hospitals to publish standard prices on the internet, is designed to increase price transparency and thus better consumer decision making. While the spirit of these efforts is to make costs more patient accessible, their execution has been poor up till now. Hospitals address this need by making their charge masters available online. They're not really easily searchable. They can be hundreds of pages long, making costs difficult to decipher for even the most skilled consumer. So one example on this page here is that this is from one hospital's website. It was 456 pages long. To try to find, if you had to find the cost of what's it going to cost for my knee replacement, it's going to be really hard for you to kind of search through all those pages to find what you need. Towards the end of 2019, we saw the president proposing a new price transparency coverage rule that would require health plans to disclose on a public website their negotiated rates for in-network providers and allowed amounts paid for out-of-network providers. So now we're talking about both hospitals and payers having to produce and provide price transparency. This makes this information available to the public. It's intended to drive innovation, support informed price-conscious decision-making, and promote competition in the healthcare industry. Making this information public directly helps the consumer, but more importantly, creates new opportunities for researchers, employers, and other developers to build new tools to help consumers. Really, the intention behind both the provider and payer price transparency rules set to begin in 2021 is to give consumers real-time personalized access to cost-sharing information, including an estimate of their cost-sharing liability for all covered healthcare items and services through an online tool that most group health plans and health insurance issuers would be required to make available to all of their members and in paper form at the consumer's request. So this requirement would empower consumers to shop and compare costs between specific providers before receiving care, which really brings us to our next trend, consumerism. Which I'm going to switch here. So as we talk about consumerism, what we really mean is that patients are shopping for healthcare. So where can they get the best value at the best price? In order to do that, they need price transparency to make an informed decision on their care. Consumers are now looking at the cost of an MRI before deciding which imaging center to go to, or they're looking at the cost of a knee replacement before deciding which surgeon to see. They're looking at the cost of infusion therapy before deciding where to receive their care. The combination of these industry trends really comes full circle to consumerism. Capturing that consumer mindshare and preference is critical for successful market penetration and product adoption. Provider, product preference, and patient experiences can make or break how you're received. This really highlights the need to effectively gain that consumer mindshare, keep their interactions and associations positive. With our age of consumerism and the diverse, provider ecosystem, we are offering individuals a lot of choices. So with 8.5 million practitioners and more growing nationwide, consumers can pick when, where, and from whom they're going to receive their services. In many ways, healthcare services are becoming more and more like a shopping mall, with consumers picking and choosing who they want to manage their healthcare and why. Effective patient engagement is a critical step to not only gain, but keep their attention. So I'd say, an example, my sister recently had a baby. This is her third baby. So as a family of 5, they chose to go to the provider system that they had such a positive experience with for their first 2 deliveries. This healthcare system is also where they go for their pediatrician, women's health, imaging, you name it. They've really gained their loyalty. And so as we continue to talk about that, this really talks to patient engagement and how important it is for the healthcare system. We're talking about not only enrolling the patient, but their families to become invested in their health outcomes, and that patient experience results in high levels of clinical outcomes. So those who have increased engagement have, decreased, medication errors, falls, lengths of stay, And perhaps the most important aspect, or one of the important aspects of patient engagement, is that a happy consumer is more likely to stay. So with each patient having a rough lifetime value of around $1.4 million to a healthcare organization, positive patient experiences influence their choices for health services for years to come. So what does that mean for you? You want your products and medications, med devices to have a positive patient experience to help capture that loyalty. So all of these trends have been going on for quite some time pre-COVID, but now we have some additional challenges to face as an industry. So we're all really feeling the impacts of the current pandemic from COVID-19. You know, in recent days, we've all seen how the population across the globe has been impacted, and that this pandemic has characteristic trends that distinguish it from others in modern history. There's a high mortality for the elderly populations and those with one or more chronic comorbidities. It's highly infectious with a longer incubation period, causing significant spread from unsuspecting or asymptomatic individuals. We've seen a very high demand for and shortage of critical life-supporting equipment like ventilators, respirators, dialysis, and ICU care level, as well as a shortage of skilled critical care personnel. This graphic from the CDC really highlights how much more likely and vulnerable the older population is to being hospitalized or dying from COVID-19 if they contract the virus when compared to the 18 to 29-year-old age group. Individuals who are 85 and older are 13 times more likely to be hospitalized and 630 times more likely to die from COVID. You know, so really looking across the United States, it's really clear that COVID has no borders, as every geography and community population has now experienced some level of exposure and loss. And therefore, we have this, the emergence of the COVID-19 pandemic has dramatically impacted the healthcare industry, and I think we all know that. Millions of Americans have been diagnosed with COVID-19. We've had close to 250,000 deaths, hitting those with comorbidities far worse than those with the lower risk populations. We've seen social distancing guidelines implemented, millions suddenly on unemployment without employer-sponsored insurance, increased social isolation and behavioral health concerns, reduced elective procedures, for folks avoiding regular cancer screenings, which I'm going to talk about a little bit later, all while inpatient settings have been stretched thin to address those suffering with severe COVID-19 outcomes. Folks have shifted more towards more virtual and touch-free options, from the way we grocery shop to how we order our prescriptions to how we engage with our healthcare providers. During this global crisis and with such a focused impact on our industry, you know, we knew as a company we had to use our resources to support the overall effort. So by combining our unique data and analytics together, we created the COVID-19 data set and interactive visualization in order to provide insights on the at-risk populations and care capacity risks. And when we say at-risk, we're really meaning the older population with two or more comorbidities, as we had just looked at the CDC, had really identified that that's that at-risk population. These insights can be used by customers, public health officials, health researchers, to really allocate resources to counties with the greatest needs. So I really encourage you all to check it out. The link is at the top right of your screen. But that really brings us to talk about, I want to talk about telehealth briefly. So where there were potential resource gaps, particularly in the beginning of the pandemic, we've seen those gaps really being mitigated through that transition to digital services. As we all know, that traditional delivery of healthcare has undergone a significant transformation with the suspension of elective surgeries and temporary closures of offices. In response, many providers have transitioned to using telehealth services for remote patient evaluation, diagnosis, and treatment. This nationwide expansion has helped communities maintain continuity of care and support social distancing requirements. And some at-risk communities have been able to benefit from vital services that reduce potential care gaps and limit patient exposure. When we're looking at telehealth adoption, though, kind of nationally across all claims and specialties, you know, when compared to 2019, there's really been an increase in that adoption utilization. So early in the pandemic, we saw a growth percentage skyrocket. So just looking at mid-March to early April, and that's not on your screen right here, but we saw it went from a 100% increase in mid-March from where it was in 2019 to an 8,000% increase in the span of just 5 weeks. So we saw this massive spike, and you'll see that kind of on the bottom right visual on your screen. It just really spiked in from March to April. And while that percent change has dropped a little bit, you know, as folks, you know, we're finding that balance of how we go back to in-person visits and figuring out when we're going in for our screenings and our elective procedures. We have still seen a large adoption from telehealth across the industry. When you kind of dive into this by specialty, You can see, which specialties have really adopted it. So 2 examples I'll share. One is the gastroenterology. So when we look at just even, a couple weeks ago, we had around, it was still a 63,000% increase over their telehealth claims last year at this time. However, they hit a peak in April with 167,000% change increase. So we're still, we saw a dip from 167,000% increase, but we're still at 63,000% higher at this time compared to where we were this time last year. So I don't think the telehealth is really going away, and I'll talk about that in a moment. Behavioral health is our other example. So it's really been on kind of our top 10 list for quite some time. Even though they had a higher adoption rate to begin with, we've really, the global pandemic has led to kind of that significant increase, even in that space. So as the healthcare industry moves more and more towards telehealth, this can be used to identify key specialties and assure continuity of care and identify the opportunities to continue and expanding this level of healthcare support for consumers. And this is just really another view of telehealth adoption by diagnosis as opposed to specialty. So as we were just talking about behavioral health, we're really seeing that the top 3 diagnoses utilizing telehealth services are folks with generalized anxiety disorder, major depressive disorder, and ADHD. So I think post-pandemic, we're really going to see some of these trends continue. So behaviors are changing. We're rethinking how we engage with healthcare. Telehealth is not something we're likely to move away from. It offers a convenience factor and can help keep some patients engaged with their regular physician appointments. So we don't really see that these services are necessarily going to go away, but certainly some services will transition back to office settings. So for some of that makes really a lot of sense, right? Mammograms, for example, we expect patients to continue to utilize and demand telehealth, though, given the increased access to care. So now I'm going to pass it over to Anya to take us through a couple more insights from a COVID perspective, and then jump into our IDN intelligence.
Perfect. Thanks, Rebecca. So in addition to telehealth having a major increased interest from our customers due to COVID, we've had a lot of interest in other therapy areas as well, one being elective procedures. The shutdown of elective procedures, putting those on hold and postponing them, caused a huge decline in both sales and just overall how many patients were getting treated throughout COVID. This was one example we had pulled up. One of the first ones we looked at was knee procedures. And you can see that huge dramatic dip that we were able to identify as COVID between the 2nd week of March. And then it started going back up again towards the middle, end of May. So really significant. We also took a look at some of the other declines that we see throughout the year. Not surprising that it's during a lot of the holidays. The one that was interesting, though, was this orthopedic conference. That's the AAOS dip that we have in the beginning. Something we've never thought about before, never looked into, but totally makes sense that that would be a huge decline when all these doctors are out at a conference. But we did a lot of running trends of elective procedures across the board for all types of procedures, and we were able to provide some great insights for our customers. We've also been able to dig into, kind of touching on what Rebecca was talking about, we were also able to dig into the most common co-occurring diseases that COVID positive patients have. So one view is just looking at who's affected by the restrictions, but now we're adding that layer of, we know these patients have tested positive for COVID. What else do they have going on? What are their comorbidities? So over the first 3 months of the year, you can see in this graph how things have shifted, the most common comorbidities, and we're continuing to see that shift even in recent months as the virus and the severity of the virus has changed. So shifting gears slightly, we started thinking about what's ahead in healthcare, looking kind of in the future of what healthcare might look like as a result of COVID. Having a family history of cancer, this therapy area was of particular interest to me and became a bit of a pet project. So I wanted to see, when we look at certain types of procedures, the screenings, the biopsy procedures, what was the impact that the shutdown or delay in these elective procedures, what did that have on cancer? So while the screenings and procedures were put on hold, cancer was not. We have a handful of common cancer screenings. You can see here, we pulled a very broad list, just wanted to highlight a few of them here for you guys. So we wanted to see how that pause ultimately had an impact on the diagnosis of oncology. If a patient has cancer, then they have cancer, but the screenings would allow us to hopefully catch it early enough to have some early intervention or treatment for that patient. And then on the next screen here, again, we just pulled out a handful of tumor types, but we pulled across the board probably upwards of 12 different types of cancer looking into this. But we were comparing the rate of the newly diagnosed patients from this most recent April and May of 2020 to those patients who were newly diagnosed in 2019. And we saw a similar significant drop to what we saw in the screenings. So along with the previous slide, none of this data was necessarily surprising, but it's very alarming to see laid out like this. And this is a project that we're still working on. Anyone with an interest in seeing more of this data, whether it's the oncology, telehealth, definitely reach out to us afterwards. We're excited to show what we've got there. So COVID obviously has presented a challenge to our healthcare and to our health systems. By having a broad and complete view of the health system, we're able to arm our customers with the data and information to help make key decisions. So an IDN, an integrated delivery network, is a network of healthcare providers and facilities that offer a full range of healthcare services, essentially creating a whole view of the healthcare continuum from hospitals to offices, labs, post-acute care services, and all those medical needs in between. From this graphic, we can see all the pieces of the puzzle that make up an IDN, and that includes child IDNs. Just again, showing the complexity of the healthcare ecosystem, how they all fit together, work together, affiliated, owned. Those are all the insights that we can gain from IDNs. So here we see that, within our IDN product as a whole, we have over 6,000 hospitals, over 11,000 outpatient clinics, over 80,000 group practices in the data, and over 8.5 million physicians. So we have to figure out how this all pieces together. All these different organizations and physicians highlight how important it is to not only have that full view of the structure, but to also understand the relationships and how each entity works and fits within the system. So life science organizations need to not only know how big an IDN is, that's commonly in terms of the number of affiliated organizations, affiliated physicians, the number of patients that come through, but being able to layer in claims data allows our customers to reassess the value of the IDNs. By combining claim insights with IDNs, our customers have been able to optimize sales and marketing outreach by being able to identify high-value IDNs and decision makers, and also increase market share by uncovering relationships between key HCPs and IDNs. So those who are familiar with some of our other products, the systems of care is primarily, the claims part of systems of care is primarily built off of our volumetrics and influence network. And those products allow us to gain insight into who are the physicians who are treating certain types of patients or performing specific procedures. We can get insights into where those procedures are taking place or how many different organizations a doctor is treating their patients. We can also get insight into referrals, so physician relationships, knowing where a doctor is commonly sending a patient who has knee pain, for example, and needs to be sent over for a orthopedic surgery. So where is that relationship happening? How many shared patients are included? And all of that information helps our customers learn more, just having market intelligence, knowing what's going on out in the market, whether it's national or for a specific geography, It also helps with physician outreach and sales and marketing efforts. And now when we layer on the IDN data on top of that, we're able to gain some additional great insights. So not only knowing how much volume, how many patients a doctor has for breast cancer, or how many organizations, the volume at the organization, we now are able to roll that up to the whole complete IDN and know how much volume one IDN has compared to another, again, allowing us to reassess how valuable an IDN might be depending on what we're looking for to create that value. We can also optimize commercial efficiency through claims intelligence and the targeted IDN affiliation data. And probably one of the most important is being able to identify the true decision makers of the product. So in this case, we're trying to figure out who should we target. We are trying to reach out to several companies. We want to know, or organizations, we want to know where to send our sales force. We have 2 hospitals, but with the claims data layered on top of that, we can see that the one hospital has over 6,600 claims tied to it, where the other one has less than 300. So having that knowledge of how many claims are actually being submitted for certain hospitals and IDNs allows us to accurately pick the hospital that has the highest volume, meaning potentially the highest, more sales that would come out of that location, more patients are flowing through there. So again, the targeting of our sales teams for our life science customers could definitely differ and be greatly impacted by layering on that claims knowledge. So here's an example that we're going to walk through. We have an IDN here called Colossal Healthcare, primarily located in Florida. And we can see all the different facility types that roll up to this IDN. And we can see all the doctors, nurse practitioners, everyone who fits into Colossal. By layering on the claims data, we are able to then kind of reassess how big this IDN is. So we already know that they have over 200, they have 259 organizations tied to them, but that equates to 5 million claims, a little over 5 million claims across all of these organizations. And they have almost 21,000 physicians submitting claims, submitting volume within one of the organizations that rolls up into Colossal. Further drilling down, we can layer on therapy areas or procedures to, again, reassess these IDNs and figure out who's more valuable and who do we want to spend our time reaching out to. In this case, drilling into lung cancer, we're able to see out of those 5 million claims in total that Colossal Healthcare has, they have a little under 17,000 for lung cancer. So they may have seemed to be a very large IDN, but for lung cancer, maybe they're not. Maybe there's other IDNs out there that are larger. We also get an update here on the number of organizations that have claims, again, rolling up into Colossal. So narrowing in on lung cancer, we dropped about 100 organizations. So only 154 of the original 259 organizations are submitting claims for lung cancer patients. And that equates to roughly 2,000 claims or 2,000 physicians that are affiliated to Colossal submitting claims for lung cancer. In addition to being able to evaluate the different IDNs, we can also drill down and see who those specific organizations and physicians are, knowing who's rolling up to these different facilities, and getting the claim volumes per organization and per physician. So you're not only comparing the whole big picture of the IDN, but within that IDN, you can drill through and figure out who are the main organizations, who are the largest group practices within Colossal that we would want to target, or who are the higher volume physicians that we'd want to make sure that we're reaching out to and targeting with messaging. And so there's a few different ways that our customers use our data and can compare different doctors to one another. This is looking at a snapshot of what you would be able to view both using our volumetrics and our influence network data. Being able to compare doctors not only on how many patients they have, how many affiliated organizations they have, and how many other doctors that they're connected to. We get insight into the primary facility, but now the new thing we can offer, layering in the IDNs, is that systems of care. So where is that doctor affiliated to in terms of the broader IDN system? So just another way that we can allow our customers to use the data for targeting and segmenting their sales teams, knowing who you want to target based on this added knowledge. And then it's a lot of data. Our IDNs, our systems of care, you throw in all that claims data on top of it, and it is just a lot of data, which is a good thing. But we were able to create this visualization tool to make it much easier to look through everything. We can flow through the systems, the IDNs, start at the top level down, get insight into who are the different organizations, both whether they go directly to the parent IDN or if they're tied to a child IDN and flow up, learning about those relationships per IDN, per therapy area, and then further drilling down, being able to dig into each organization and find all of their affiliated physicians. And you can go the opposite way. You could start with the physicians and drill your way to the top. So this allows for a lot of great functionality. It's just a little easier to use than digging through a bunch of different data files, but we certainly have that as well. So I am going to pause there and I'm going to turn it back over to Rebecca. I know she was instrumental in helping to get this UI off the ground and tie it all together. So Rebecca, anything else you wanted to add here?
No, I think that you did a great job, Anya. Just, you know, we really understand the IDNs, and the IDN structure is can be really fairly complex, and IDNs can span geographies, and you know, we can have an IDN that has, you know, networks and systems that cross all over the country. So trying to figure out how to position your sales team and who's going to target who, you know, I think that the layering the claims allows you to target more accurately and to understand who those key decision makers are, because we know that the landscape has changed over the years, right? So, you know, the visual tool, or whether you do a flat file, both, you know, the data itself gives you those insights. You know, everyone's got kind of a different preference on kind of what they need, if they want something more interactive versus, you know, a file they can ingest into their own system and work with their own data, you know, analysts to find their own insights and cut, you know, do territory breakouts and things like that. But the intention really is that we want to help, you know, focus your efforts based on where your claims, where the claims data are, because it shows you where, based on a certain therapy area. So you're not just looking at, excuse me, I'm not speaking very clearly. If an IDN has a large system, right, and they have, even if they have a lot of claims, do they have the right claims for your therapy of interest? And so that's where claims really becomes highly valuable when you layer the two on top of each other. So, and being able to navigate those relationships and figure out who the new decision maker is, maybe versus who you used to target, you know, there's a lot of value here. So we're excited to kind of talk about it. And I know we've had some questions coming in about this. I'm just going to move kind of to our questions page so we can kind of just dive right in. So I think, Anya, I'm going to turn this to you just for this question. I think that you can take this one because this comes up every time we do any presentation, is really how often is the data refreshed?
Yes. So for the data that we use to build the systems of care view, we have about a 6-week lag from the end of quarter. So we're updating this data every 3 months. We do have additional data feeds that, or actually the majority of our data feeds do come in on a daily basis. So that allows us to build other projects such as those COVID trends and early alerting, but that systems of care view is updated every 3 months.
Perfect, thank you. I'm just looking through. So another question that came in on, can we provide the detailed definitions of claims data? So are we talking about, you know, exponent prescription, APLD, or what are we talking about here, Anya?
Yeah, so when we're talking about claims data from Lexisnexis, We're looking at medical benefit claims that the hospitals and physicians would submit to the payers. So this is not prescription data. This is not electronic medical records. These are the medical benefits that are being filtered through switches and clearinghouses onto the payers.
And I'll just add a little bit to that. So some of the information that comes in from a medical claim or a submitted claim is looking at diagnosis. So the ICD-10 code for the diagnosis, the procedure, so CPT. We've got HCPCS codes for medications that were administered, some basics on patient information. So location, age, gender, it's all de-identified, but we're able to, you can kind of run through this information. This is what comes in on your medical claims though, right? So then the payer, so who's paying, who's responsible for the payment, the practitioner prescribing the care in the facility where it was provided. And not so much in the solution that we're talking about, but still a claims data source that we pull in are the submitted remittance information. So while there is not diagnosis information on the remittance data, they're sharing with you, or the information available is like procedure information, so the CPT codes, the procedure details like modifiers, units, the allowed amount, allowed amount, paid amount, charged amount, and we can look at adjustment codes, and you can look at patient responsibility, the payer, the payee, and then the place of service. So when we say claims data, we're really talking in this particular presentation mostly about the submitted claims, but it's important to know there's the second level of that, or the other side of that same coin, is the remittance information that we have that comes in here. So I'm going to go back to our question slide. And we've had quite a few questions. So Anya, I don't know if you want to take this one or if you would like me to. We had what percentage of your claims is tied to an IDN? So how much of our assets are tied to an IDN?
Yep, we were prepared for this. We figured we'd get this question. So we estimate that roughly 82% of our inpatient claims are tied to an IDN. Roughly 87% of all inpatient practitioners get tied to an IDN, and then about 70% of the outpatient claims and practitioners.
Perfect. And we have a lot of questions that are coming in, so I'm trying to just sort through which ones are possibly related to that.
Yes, and I separately see in our chat we had a question about, are we able to assess what's happening at the DRG level? So I'll take a stab at this one. We are able to pull some of our data assets based on a DRG code as opposed to an ICD-10 or HCPCS and CPT code, or combination of everything. Volumetrics, one small piece of our systems of care deliverable, can be built on DRGs. I am not sure if we have explored building our whole systems of care on a DRG code though. Rebecca, do you have any background on that?
I apologize, Anya. I did not hear the entirety of what you said because I was reading through all of our questions.
No.
But I don't have any more information on DRGs though, outside of what you said. I trust you.
Okay, yeah, so that's definitely something that we can look into. So I believe Erin asked that question. I'm not sure if we get your contact information, but definitely reach out to us and we'll give you an update once we ask our analytics team if that's something that's possible.
One of the questions that came in was the coverage of the claim data on the HCP level, and especially in the oncology space. So I think that that's something we would have to get back to you on specific to an oncology space, but we certainly have that, like with that 87% of all inpatient practitioners are tied to our IDNs, and 70% of our outpatient practitioners are tied to the IDNs. But if you have an interest in something specific like oncology, just reach out to us for, Anya can run some samples for you and pull some of that information. So hopefully that answers.
And that matches great with a question that we got a little earlier. Is there a version of the data that could be shared with clients that might be interested in this? Yes. We love running samples for our customers. So if there is a specific therapy area, whether it's maybe all of oncology or specifically want to drill into lung cancer, reach out to us, we can run a new up-to-date data set. We'll filter on a couple of IDNs to provide that data over to you guys. We like to have a quick call just to run through everything, make sure our customers see all the different pieces, understand what they're looking at, and then we actually turn that sample over to our customers. So you guys can kind of play around with that data, share it internally, and hopefully come back to us and want more data. So happy to run samples. We really just need to know therapy area and geography of interest.
I think we have one question that came in, and I'll take a stab at this, Anya, is can you give me an example of how a customer has used this data? So we said customers have realized that kind of their buyers and key decision makers have changed. So we talked about that a little earlier as IDNs have emerged, and those teams are looking to get in front of the right targeted audience. So knowing the IDN structure for their geography and therapeutic area of interest has allowed them to really focus their targeting efforts to get their products in the right hands. So for example, the ability to better understand treatment behaviors in areas of clinical and surgical specialization with the IDN allows brand teams to produce more powerful and focused messaging to present to the purchasing decision makers. So great question.
And we have a few here around the IDN. How do we get IDN and tie that with claims data? Is it coming off of the claims data? So Rebecca, please elaborate on this, but we take the IDN structure from our provider master file. I do not know where we get the IDN information, but we link that in with our provider master file. So that's where we're able to see the NPI numbers that come in on claim forms. And we tie that to the appropriate organization name, doctor name, identifier that we have to match it up to our master file, which then we can filter through with the IDN data. So again, Rebecca, I don't know if you have more background on how we build the IDNs. From my view, that's already built and comes over to us, and we do our click on.
Yeah, so we have a team that's dedicated to going out and finding this information out. They do sourcing, and then they run it through, a series of, algorithms to make sure that we don't have, duplicated IDNs and everything's kind of up to date. So that's when they marry it up to the master file information to make sure we have the most accurate, provider information, so addresses and MPIs and all of that. So we're sourcing it from different websites. I'd have to do a little bit more research on what specific ones. I know there was a question on the sourcing, but we have a team that goes out and does this on a regular basis, and we update that, and then that gets linked into the master file data, and then when it's passed over to adding on the claims, we're really, you could start to see that we're layering in, what's the basic structure that exists out there. From an IDN perspective, we layer on all of our additional intelligence on it as far as making sure it's really validated and high, the highest quality for your provider, so you're not getting, a provider or an organization that has either recently closed or a provider that's deceased. So we're pulling in all of that information, and then we layer on the claims to really make sure that we're targeting the solution for you based on what claims have been submitted through that IDN. And we know that providers, so a provider is not necessarily tied to one IDN, right? So while a office setting, for example, would be tied to an IDN, a provider might have the ability and freedom to work with multiple IDNs. So within this product for us, we're not deduplicating the provider. The provider may show up in multiple IDNs, and so one of the pieces of our user interface that we were looking at, Anya had showed us, is you can really drill into just even the practitioner workload to see where are they performing their volumes, and if it's within certain IDNs or certain organizations, you can start to see where they're doing most of their care. So while the practitioner is not tied to a specific IDN, we do have all of their information tied to their organizations. As long as we see it in the claims data, then we're going to see it there. The product also pulls in providers, so you can do it without looking at claims. So you can, especially within our UI, you can kind of toggle the claims and associated or not. So if you want to see just the total number of practitioners or agencies that are in the IDN, even without the claims, just to start at the high level of what am I looking at here from the large picture, and then you want to drill into claims, you can do that. And that's because we know that there are certainly we don't have 100% of all claims out there, and we don't have 100% of the full picture without pulling in what those providers are, even the ones that we don't have claims on. So we make sure that you guys have that as well, because we know that's an important piece to understand the full picture. Anya, is there anything you want to add to that?
Yeah, that's covered it. So it looks like we're down to about 3 more questions. If anyone else has any other questions, we've still got plenty of time to be able to answer them. 2 more here that are tied to claims data, so I'll take a stab at those. When looking at the claims data, what % of procedures link back to a diagnosis? I actually don't know. I would imagine it's a high number, and I can look into that as a takeaway. Every claim that gets submitted is required to have a diagnosis code. And then commonly they will have a procedure code of some sort, even if it's just an evaluation and management code. So when you go to the doctor's office, whether it's to have a knee procedure or you're going in because you think you have a cold and you just want your doctor to check you out, you're always going to have a office visit code show up. So in that sense, it would be a very high percentage of claims that also have a procedure code on it. We can also link up data sets where we require both a diagnosis code and a procedure code to be on the same claim form. For example, if we wanted to drill into breast cancer, but we only wanted to reach out to those doctors who treat patients with radiation treatment, we can silo that in and make that a requirement. So we're only pulling in claims with breast cancer and a radiation therapy code on it. So I don't have the exact number, the percentage of how many procedures link back to a diagnosis, but looking at the claims as a whole, I would imagine it's a very high percentage that would also have a procedure code listed on the claim. And then the other one, similar question, but thinking back to prescriptions. I do not have this answer. We don't get any prescription data in-house. That's one data asset that we don't have or pull into our data set. So I don't know what % of prescription would link back to a diagnosis. I would imagine it has to be high, but we don't know that from our data.
Thank you, Anya.
And then I'm going to pass that last question over to you.
I have this one question here, and I think that there was another one that came in, so I'll do both of them. So one was, can you please explain more on APM? So this was earlier in our presentation, we were talking about alternate payment models, and there's options 3 and 4. The options 3 and 4, I think really the difference is that option 3 and 4, or 3 is really looking at when you're starting to see the upside, potentially some downside. So where, you know, if a provider and, you know, the 10 other providers that they've decided to contract with see some positive change or outcome, they get a positive reward for that. But if there's a negative outcome, they don't necessarily see a downside. But some of those models are starting to see that downside, where if someone does not get better in their care, there is a risk associated with that, or a reduced payment for that, versus option 4 is more of that full risk and like the upside and the downside associated. So you're really more responsible for the overall health care of the individual. So let's say someone goes in for, I'll say my background was in behavioral health care, and someone's going in for, you know, an evaluation for substance abuse, and you follow that person's course of treatment. If they get better, whatever is defined in that contract is what better means. If they got healthier, or they, you know, go to a certain number of treatment sessions and they have abstinence for a certain period of time, if they meet whatever those goals are or those metrics, then you have that upside. But if they do not, there is a downside risk. There's, you know, inherent challenges in any type of like chronic condition like behavioral health, or, you know, diabetes or something like that, where it's chronic versus acute. So those would look a little bit different based on the types of conditions. But those APMs really stack kind of in fee for service, and then, you know, getting paid for either reporting, you know, paper reporting or paper performance a little bit, and then it starts to get to be more and more where you're seeing the upside or the downside in the full payment. So I hope I answered that question. If you have more on that, please let me know. And then Anya, I think one more that just came in, if you wanted to touch base on this, was what payer types are included. Do you have information on payer? And if you do, what payer types are we bringing in?
Yes, so we are looking at all payer types in our data. We capture Medicaid, Medicare, commercial data is coming in. When we look through all of the payers that we have, whether it's for all of our data as a whole, or even drilling into certain therapy areas, we're really seeing that we have great capture of all of the major payers, both commercial and Medicaid across the board. And with some of those samples that we pull, we actually do provide a quick little payer mix just so you can see for whatever therapy area is of interest to you. You do get that snapshot of who are the top payers that we're seeing submitting those claims. So we're pretty well rounded in terms of all of the payers that we're capturing. No significant gaps other than I would call out Kaiser. We don't get Kaiser because they're a closed health system, but that's the only payer really worth noting that we would not have in our data.